so everyone's aware of this. As you're thinking about how we engage together as a community, just some reminders here about the use of Zoom. If you have a video camera, you are invited to use that. We would love to engage with you and make this more human engagement with seeing your images. The other is the use of unmute yourself and when you want to contribute or comment, and please mute yourself if you're not engaging in a conversation. And here, when you want to contribute, please speak up. You can also use the chat feature, which I will be monitoring, and you can also present your questions on that feature as well, right? Don't forget to mute again after speaking. Today's presentation, including the first presentation of this series, is being recorded, and the recording will be made available to everyone by request towards me at this email, epenate@nm.org. So if you want to obtain the video, or you know of colleagues that are interested in this video presentation, but in the previous and the third presentation, please let them know that they can obtain it by request. Okay. Again, this is part 2 series of a 3-part series on religious spiritual struggle. We started off with a great presentation from Dr. Pargament on religious spiritual struggle, and he really provided a good foundation and the background on the evidence and the investigation that we have had from previous efforts. And today's guest speaker, which I will introduce in a moment, will be focusing on the methods that to screen for RS struggle. And he'll say more about this in a moment. And then our final presentation will be on Friday, offered by Dr. Pierre, and she will have, from her background in trauma work and the clinical setting, she will also offer some contributions to consider when RS struggle is observed with the African-American population. Right. So a few words about our guest speaker. Building off the first presentation of Dr. Pargament, our second presenter is Dr. George Fitchett. He will focus, as I mentioned, on the methods to screen for RS struggle. Dr. Fitchett is an ideal presenter of this topic because he has been a seminal figure in the field of spiritual care research. His research has examined the relationship between religion and health in a variety of community and clinical populations. He has been a key figure with advancing evidence-based practice in spiritual care. He has created a strong empirical base on spiritual assessment, and will not be surprised to find his name pop up in many of these articles when we do a search for spiritual assessment. His work are key publications and widely read by many clinicians. I'm very grateful to have you share with us today, Dr. Fitchett. The time is yours, and I will stop my sharing.
Edward, thank you. I'm going to stop talking for a minute and do the screen share, because I can't talk and do this technology at the same time, can I? There we are, right? Can you see the slides?
We do.
Good.
Yeah.
That's great. All right. Yeah, so a pleasure to be with you all today. Edward, I really appreciate the invitation. Always enjoy collaboration with Edward and Northwestern colleagues. Look forward to kind of having a chance to share with you. I was thinking of covering these 4 things for the presentation. Talk a little bit about what spiritual distress is, talk a little bit about the prevalence of it, talk about the research about the harmful effects of religious spiritual struggle, and then talk a little bit about resources for screening. The photo there, if you're a longtime Chicagoan, you may have seen this photo. It was about 15 years ago. It was in an underpass under the Kennedy Expressway. And it actually became a site for devotion for people who felt like it had miraculously appeared in the underpass, and a figure that kind of represented Holy Mother, and so many people actually came, prayed, lit candles, brought flowers there. So kind of always intriguing to me as a kind of image about the intensity of religious devotion that can happen at times. So, as we kind of jump into the topic about religious and spiritual struggle, this is a quote from a woman in her 50s with advanced cancer who was talking to a chaplain at our place. And in that conversation, she said, why me? I just can't figure it out. And I get so depressed. I just want to give up on life altogether. And I'm so very angry at God. I'm so angry. I refuse to speak to him. You know what I mean? So very familiar, right? Those of you who've been working with patients and families with serious illness, advanced cancer, you've heard things like this as a kind of, I think, an important representation of what we now understand to be one dimension of religious and spiritual struggle. So this is a kind of the ballpark that we're in, right? Is patients who are feeling this way and feeling intense distress. So, just to elaborate on it a little bit more, and you may have heard some of these things from Ken Pargament when he spoke with you a few weeks ago. One way to think about religious or spiritual struggle is that it's religious or spiritual tensions that can happen internally, just inside myself, my doubts, my struggle for meaning, religious and spiritual tensions that can happen with others or around religious and spiritual topics. Mom, if you just prayed more and you, et cetera, then you'd be healed. Why aren't you praying more? It's those kinds of things. And it's religious and spiritual tensions with what one holds to be sacred. So as we saw in the quotation, the sense of being angry with God, for example. So as we think about religious and spiritual struggle, we think about it as including all of those different ways in which people struggle to find meaning and purpose. It can include the struggle with the divine, feeling abandoned by God, again, feeling in conflict interpersonally with others around religious, spiritual beliefs and practices. It can be that internal struggle with meaning. And there are multiple terms that in some sense have important distinctions, but in other sense, they're kind of all pointing in the same direction. So we'll use them kind of interchangeably. The literature talks about spiritual pain, spiritual risk, religious spiritual struggle. And as you probably heard from Ken Pargament, one particular way in which he has measured religious spiritual struggle is with what he calls negative religious coping. So hopefully we've kind of got ourselves on the landscape here. What is it that we're talking about when we talk about religious spiritual struggle or religious spiritual distress? Just one other point, and again, this is probably something that Ken covered with you, but just to remind you that one of the best measures of religious spiritual struggle is one that Ken and his colleague Julie Exline and others developed. It's almost 20 years ago now, right? 18 years ago, the religious spiritual struggle scale. And that's where they identified the 6 components of religious and spiritual struggle. So I've kind of already hinted at that, right? The first 2, struggle with the divine, struggle with the demonic, can be examples of religious and spiritual struggle with divine power, demonic power. The third one is that interpersonal religious struggle, and the last 3 are those different dimensions of intrapersonal religious struggle, doubt, struggle around violating important beliefs and practices, kind of moral struggle or guilt, and then that sense of struggle around finding meaning and purpose in life. So I think we're kind of going to shift now. Oop. There we go. We're going to move from defining it to talking a little bit about prevalence. So this is a study, 21 years older now, from MD Anderson, 113 palliative care inpatients who routine practice at MD Anderson. The palliative care inpatients had an in-depth spiritual assessment from the chaplain on the team, who used a structured spiritual assessment model that had 7 dimensions. You see the 7 dimensions in the little table at the top: despair, dread, broken, helplessness, etc. And what they did is they went back and did a retrospective chart review, and they looked at consecutive admissions for 113 patients. And the chaplain went back and counted. He examined his spiritual assessments, Chaplain Steve Thorney, and he reviewed his spiritual assessments, and he said, for this patient, across the 7 domains, how many of them did I think this patient was experiencing struggle in? And was it none of the domains, none of the 7, 1 of the 7, 2 out of the 7? And you see the distribution here, which is something that just caught my attention when I first read it. I continue to think about it a lot. Essentially, 50% of the patients had either no struggle or spiritual distress as assessed by the chaplain, or distress in one of the 7 areas. Right? So basically half of these patients had essentially little or no spiritual distress. That's hard to imagine a patient population that potentially has more distress, more reason for distress. These are patients with advanced illness, being treated by the supportive palliative care team at MD Anderson, whose condition had worsened sufficiently that they were admitted to an inpatient palliative care program. So extremely, extremely sick people, right? Facing the end of life, advanced illness. Half thorough spiritual assessment by an experienced chaplain. Half had little or no spiritual distress. That's just kind of important, I think. But 1 in 4, basically, had pretty intense spiritual distress. So it's this kind of uneven distribution, isn't it? A whole bunch of people who are doing well, and a substantial number of people who are actually not doing well. So that distribution caught my attention, and I kind of just continues to stick with me. And as more research has been done in this area, we have done some of it at Rush, other people have done it. There's a sense in which this pattern seems to be coming up in other data. So some colleagues and I a few years ago developed a new quantitative approach for spiritual assessment and palliative care. We call it the PC7. And some colleagues at 2 academic medical centers used the PC7 with a number of their palliative care patients. So there were 62 patients here. The little table on the left-hand side shows you the basically 6 themes. The 7th is other that are in the PC7, and the proportion of patients who were scored by the chaplain as a 2 or a 3, so a moderate or intense kind of spiritual distress is what we mean by 2 or 3. But then the pie graph kind of gives you our distribution. A third of our patients, 35%, the chaplains didn't see moderate or high distress in a third of our patients. In this sample, 42% the chaplains saw high distress in one of the 6-7 areas, and then again 25% where the chaplains were seeing high distress in 2 or more of the areas that were being assessed. So not identical pattern to the MD Anderson team, but some interesting similarity. So then, I began to kind of read the literature and look, and here are 5 different studies. The first one is the MD Anderson study that we saw the green bar graph. And the second one is also from MD Anderson, using a measure of spiritual pain. We'll look at it in a few minutes. It's a kind of, on a 0 to 10 scale. How would you rate your spiritual pain? The next one is 300 patients receiving palliative care, cancer outpatients. It's actually a multi-center study. Both Rush and Northwestern were part of this. And this used that 6 DMin religious and spiritual struggle scale that Exline and Pargament developed. The next one is actually a study of 1,000 palliative care patients, advanced care patients living at home in the Netherlands with a measure of spiritual needs. And the last one is actually 260 palliative care patients, life expectancy less than 12 months, a study from Australia. And as you see, the different measures of spiritual distress, spiritual pain are happening here. And then you see the proportions. I've kind of tried to slice them into proportion with no spiritual pain, low levels of no spiritual pain, and then moderate or high. So look at the last row, because the last row is my summary, right? So across the 5 studies, we see somewhere between a half to a third appear to have no spiritual pain. Somewhere between a quarter to a half may have low levels of spiritual pain. And then we see between 10 and 25% have moderate high levels of spiritual pain. So this kind of pattern of prevalence, again, similar to the original MD Anderson study we looked at, a high proportion of patients with serious illness don't seem to have intense religious spiritual struggle, at least as we can best measure it, but somewhere between 10 and 25% seem to be suffering quite a bit and certainly need our attention. So why is this important? Well, in and of itself, experiencing spiritual struggle, spiritual pain is just, it's just painful. It just doesn't feel good. As we saw from the quote from the woman with breast cancer at the beginning. But the evidence is that it's also, associated, as we might expect, with high levels of emotional distress, poor quality of life, sometimes more symptoms. And you'll see here some of those associations. These 3 studies happen to be cross-sectional associations. So we know that with cross-sectional data, it's not clear, is this a chicken or an egg here? But there's also longitudinal research about religious and spiritual struggle in different clinical populations. And you'll see here 4 studies, stem cell transplant patients, breast cancer patients, congestive heart failure patients. And longitudinally, kind of baseline, higher levels of religious spiritual struggle measured in different ways are associated longitudinally with, again, poor, high levels of emotional distress, poor emotional well-being, poor life satisfaction, and actually greater utilization of healthcare, poor physical functioning, poor adherence to recommended clinical guidelines. So what's the takeaway, right? There's a lot of patients who don't have religious and spiritual struggle or who have low levels of it. patients who have moderate to high levels of religious spiritual struggle. It's costing them a lot. It's emotionally draining, it's spiritually draining. It may be compromising physical function, and certainly deserves our attention. So I think I just did this summary, right? A whole lot of patients and families are coping quite well. A smaller proportion are having a very tough time. And the possibility that things can change quickly, that people who are actually coping well one day, but actually are plunged into religious spiritual struggles soon after, we actually don't have good data about the trajectories of religious spiritual struggle, about the fluctuations of it. That's really a kind of important cutting edge for the research here. But we just know clinically that sometimes people are coping well and then something happens, new diagnosis, readmission, recurrence of illness, treatment is no longer successful, et cetera, et cetera. Just because someone is kind of screened without struggle at one point, that doesn't mean we don't want to be very sensitive. So all of this, right, clearly points to the importance of screening, identifying people who are potentially experiencing moderate to high levels of spiritual distress. So this is, we'll kind of get down to the nitty-gritty here about how do we do this screening? What are the practicalities of it? I think probably the first thing to think about is that the approach to screening varies by clinical area. If you're talking about the palliative care inpatient unit at MD Anderson, I don't think we're talking about screening. I think we're talking about in-depth spiritual assessment by an experienced, well-trained chaplain who does an assessment on every new admission. This is just a population with high likelihood of religious spiritual struggle, and there just should be complete 100% kind of in-depth assessment for patients like that. And that may be true in some other clinical settings, right? Maybe in some of our ICU settings or some other places that you can think of where screening is probably not the right approach, that we really need to get right to in-depth assessment. But there are other contexts where screening is actually exactly the right approach, that we have a high level of patients who may be coping well, but there is a subgroup that's not, and we need to kind of figure out which people are in which group. And our outpatient clinics, other managed care settings, may be exactly the settings where we need good screening tools. It may be that on the inpatient palliative care consult services. Similarly, a lot of patients may be coping reasonably well, so the screening may be the best place to start. Sometimes those would be screening questions that non-chaplain clinical colleagues can include in the history and physical. There may be some contexts where patients are filling out a bunch of surveys on a tablet before they come into the clinic or when they get to the clinic, and it maybe we can put the screening questions in the tablet and let them do it that way. But the important point, right, is that we don't have enough chaplains in any palliative care service to be, doing all of the screening 100% of the time for all new patients. That's just not smart, realistic. So we need colleagues in the interdisciplinary team who are trained to kind of think about religious spiritual struggle, to be asking screening questions about it, to be alert when a patient is screened negative one day, but something has changed the next week, and to kind of rescreen or, ask the chaplain for a consult and an assessment. So that's just essential for colleagues in non-chaplaincy colleagues in the interdisciplinary care team to be alert and sensitive and doing screening and making referrals here. So how do we do it? I'm going to talk about 3 different approaches. There's a bit of research on all of these that suggests that any one of them can be effective And there's not enough research at this point to suggest that one is clearly superior to the other in terms of, the kind of hardcore sensitivity, specificity kind of research. So the first one we look at here is actually a question about spiritual pain that has been added to the Edmonton Symptom Assessment Scale. So you see it's now known as the ESAS-SFS because financial and spiritual pain have been added to it. And the spiritual pain item is down at the bottom. So in addition to kind of asking patients to, tell us how much anxiety you're experiencing from 0 to 10, or how much shortness of breath you're experiencing from 0 to 10, this item says, tell us the extent to which you are experiencing spiritual pain from 0, no spiritual pain, to 10, the worst possible spiritual pain. Now, when I first saw this item, I said to myself, that's a little vague. How are patients going to know what we think or what we're asking them, right? But the item includes this description, right? By spiritual pain, we mean pain deep in your soul or being that is not physical. Well, that's an interesting description, isn't it? Pretty broad. The MD Anderson team is the team that has used this item the most, has published the most research on it, probably 4, 5, 6 different papers now. The associations between spiritual pain and other symptoms on the Edmonton scale are in the directions that you would expect, and often are statistically significant. So the item is performing in ways that are consistent with other measures of religious and spiritual struggle. The prevalence that we see when the item has been used in populations at MD Anderson, and Marvin Delgado-Guay and his colleagues have actually published a recent paper where the item was used in both Hispanic patients in the southern US and several samples from South American and Central American countries. The prevalence that we're seeing for the item does suggest that it's functioning effectively. So there hasn't been formal sensitivity, specificity kind of research about it, but the research that we've seen suggests it's a good approach to screening, and it's certainly very efficient, easy for patients to understand, and I think definitely recommended for people who want to have a very simple one-item approach to screening for spiritual pain. And as you know, the kind of cutoff is 4 or higher would be indicated moderate to high levels of spiritual pain. So 0, obviously no spiritual pain, 1, 2, or 3, a low level, and then a score of 4 or higher would indicate definite need for referral to the chaplain. So the second approach to screening, not quite as simple, but still not too hard to understand, was one that we developed at Rush probably about 20 years ago, been used in a number of different studies in different clinical areas. Begins with the question, is religion or spirituality important to you as you cope with your illness? And the 2 possible responses are yes and no. The data you see here is data from an outpatient primary care practice for older adults who had screened positive for depression. So is religion, spirituality important to you as you cope with your illness? If the patient says yes, the follow-up question is how much strength and comfort are you getting from your religion, spirituality right now? And there are basically 3 choices. I'm getting all that I need in terms of strength and comfort. I'm getting less than I need in terms of strength and comfort, or I'm getting none at all. And the latter 2 choices are indications in this protocol for religious spiritual struggle. But we don't assume that religion, spirituality is important to everybody. So some people may say no in response to the first question. And we don't want to assume that people who say no, it's not important to me, are all happy, well-adjusted atheists. There may be a subgroup in here who say religion, spirituality is not important to me because exactly of religious spiritual struggle, that there's been some alienation from religion, spirituality, some sense that God's not answering prayers, some ways in which interpersonal religious dynamics have just really been toxic. So the follow-up question here is, has there ever been a time when religion, spirituality was important to you? So no, it's not important now. Yes, it was important in the past, is the second pathway for potential religious spiritual struggle. And if a patient screens positive on either of those pathways, then that's an indicator for a referral to the chaplain. And obviously, if there are resources to allow chaplains to be referred to any patient who wants one, that we certainly want to be allowing for that, and hopefully can staff for that. But if the chaplaincy resources are limited, and we have to be careful about that in terms of being sure that we direct chaplains to the patients with religious spiritual struggle, here's a second approach to screening. And a third approach to screening, and the last one that I'll talk about, and we're really coming down the home stretch here, so glad for your comments and questions in a few minutes. This comes out of a paper, first author was Stephen King at Seattle Cancer Care Alliance. And Stephen and his colleagues in the outpatient cancer setting have been using these two items. Do you struggle with the loss of meaning and joy in your life? Do you currently have what you would describe as religious or spiritual struggle? These data come from a long-term follow-up study of stem cell transplant patients at Seattle Cancer Care Alliance. So most of the patients that were participants in this study are people who are long-term survivors of stem cell transplant, 5-year survivors, 10-year survivors, sometimes more. But Stephen and his colleagues have used these items actually in the kind of patients who are actively receiving treatment as well. So if a patient says not at all in response to both questions, then they are considered negative for religious and spiritual distress. If they say somewhat, quite a bit, or a great deal to either question, then they are considered positive for religious spiritual stress. And this paper, for those of you who want to get into the nitty-gritty, is a paper where Stephen and his colleagues actually compared sensitivity and specificity for single items and multiple items to scores on an earlier version of Ken Parkman's negative religious coping. So the selection of these two items, they had the best sensitivity, they didn't have great specificity among all the different things that were tested. So those are the screeners, and I think this is probably my last slide, and I'm glad to hear your comments or questions. Where do we need to go with the research? You know, that just on the one hand, we've got some good starts with the research, but on the other hand, there's a lot more we need to do. So those of you who are in settings that can not only use some of these screening tools, both clinically, but gather data about it, that can be very helpful for all of us. You know, so we need to use the tools in different clinical settings, and we need to be able to describe what proportion of people are screening positive or proportion that are screening negative, and you know, look at whether or not that's varying across specific populations. We really don't have good research about, you know, the screen is working better for men or women, young or old, racial ethnic minorities, people from different religious backgrounds, or people who don't have any particular religious or spiritual background. So all of the kind of subgroup analysis that you would want to have around good screening tools hasn't been done yet. We haven't had the opportunities to do that kind of research. We've seen some evidence that, positive screen on different tools. For example, the spiritual pain item from the Edmonton scale is associated with worse symptoms, but we need obviously more research about that. As I mentioned earlier, we definitely need a lot of research about the trajectory. Is there a clinical population where we can use the screening tools in the context of multiple encounters, so that we can look at how the indicators for spiritual pain using the tools may change over time for different people, and particularly, of course, important is, for whom is spiritual pain chronic and persistent. Presumably that's the group that's paying the biggest price here, and learning more about who that might be, what are the predictors of that can help us identify those folks to be sure they get good referrals. And then, in addition to the descriptive research, we need to kind of identify what are the best interventions to help people resolve religious spiritual struggles. Spiritual care intervention research is a pretty new area, and we just need to be able to do more of that, and to be able to describe whether or not spiritual care is effective, for which people it is most effective, and where is it not effective, and what does that mean for how we need to perhaps improve our work and do it better. And I think, Edward, I'm done. I'm going to leave the slide share on for a few minutes in case anybody has any questions about specific slides. But I'm really happy to kind of hear, are there comments, questions that people have? And I can't see everybody's picture, so if people have comments or questions, happy for folks to shout out.
Thank you, George, for taking us through this process and also highlighting the screeners for us to consider here. Appreciate it. I do have some questions that they have been sharing in chat. One goes back to referring to your slide number 8, and is where you highlight the different studies there and the range across studies. And their question from Stan, what should we make of the fact that the lowest levels were in the Netherlands and Australia, countries that are more secular than the US?
Hey, Stan, great to see you. Great question, man. Yeah, what do you make of it? Yeah.
Well, it never hit me until I saw this particular slide. Is, context is important, and how much of this is a reflection of the culture.
You want to go the other way, that the highest proportion is in Texas?
Well,
That's
far be it from me.
Yeah, exactly. I mean, we shouldn't be stupid about this. But so there's a lot of things going on here, right? There's the whole different ways in which religion, spirituality is culturally shaped, isn't it? And to what extent are expressions of religious and spiritual pain and distress culturally specific? So, if we go back to the in some sense, the state-of-the-art measure from Ken and Julie Exline, is this really a kind of measure that will work the best in a North American context, or even a US context, where the vast majority of people are Christian? Ken and his team have done actually a lot of interesting work about religious and spiritual struggle in non-Christian religions. So there are earlier versions of the spiritual struggle measures for Jews and for Buddhists and for Hindus. So it's not like it's just a Christian thing. And it's also not like it's only a certain kind of Christians who experience struggle, and that humanists won't have it, or Unitarians won't have it. It's just a kind of people from certain religious groups. And another way to think about this is, in some sense, I mean, it's hard to think of a more secular country than the Netherlands, actually. I mean, it really, their kind of established religion is really not very prominent. Huge proportions of the population identify themselves as not religiously affiliated. And here you go, 17% had moderate or high levels of struggle using the items that they developed for their context. These are items, the measure in that study is actually a measure that was created in the Netherlands for the palliative care research. So, how much of this is the cultural specificity of struggle? How much of this is the way that it gets measured? All areas for continued research. But a great point, that the cultural context may be a very important part of this. I mean, one of the important things that Ken Pargerman has said, and he may well have said this when he was with you all a few weeks ago, is that part of what makes religious and spiritual struggle worse is that if people are in interpersonal or communal contexts where it's stigmatized, so that if you are part of a faith tradition where strong faith is expected, even in the midst of very, very hard times, and lament, right, to kind of use a kind of term from religious traditions, that lament about feeling God forsaken, which, is an important part of religious tradition, particularly notable in the Hebrew Psalms. If you come from a tradition where lament is understood as part of the journey of faith and not an act of unfaith, Ken would say that probably is a predictor of a better ability to integrate the struggle versus getting isolated in it. So again, the cultural context probably means an awful lot here. The religious context means a lot. One of the ways in which it may influence how toxic religious and spiritual struggle might be is the extent to which it's stigmatized by the culture you're in versus understood as something that happens to faithful people in the journey of faith. That felt like a very long answer. I'm sorry. But
no, thank you. That was a great question. It elicited a lot. So thank you for that, Stan. Anyone else? Anyone have a question, comment, or a surprise, or something you're still noodling on?
Well, if no one else will step up, how often would you recommend repeating the screening, especially for non-chaplains, for clinicians?
yeah, thanks, Stan. I wish we had research that would help us answer that question. And as far as I know, we don't have any research that tells us that. So, as clinicians, what would be the guideline in terms of how frequently you want to screen for other things, such as, depression? On the one hand, what Commission on Cancer says, we have to screen cancer patients every time there's a new clinical encounter, and if somebody's coming into the clinic once a week, that's kind of nuts, right? I mean, patients just get burned out with all the screening. Do you want to do screening on the first encounter when you're getting acquainted? Do you want to kind of rescreen if there's no kind of important clinical change every 12 months? And if there's some important clinical change going on, do you want to rescreen at that time? Off the top of my head, those would be the guidelines I'd recommend, but I'm happy for other thoughts about that. I wish we had the research that would tell us actually what's the best practice.
Thank you, George. I do have a follow-up question with the screening piece, especially as we get non-chaplains, clinicians involved, and when a patient says, I don't want to see a chaplain, right? And what does the clinician do with that, right? And what this means in terms of training for the clinician and other members, because there will be persons that will say, will probably prompt us probably high or moderate level of RS struggle, but they'll say, nope, don't get that person in here, right? And I connect this with the information that you shared about this is harmful. This is a real thing that is impacting the well-being of a human being. So what insights would you offer?
Edward, what if I turn it back to you? I mean, what do you advise your team if they get in that situation? Do you have a recommendation for your team? I'm happy to jump in here,
yeah.
but I also want to kind of get a few other perspectives.
Yeah, no, thank you. I should have expected the boomerang. And so, and that's because you're familiar with what I do. And so this has a lot of implication about how we are trained as a clinical team. And what that means in terms of a non-chaplain clinician is that there is a need for generalist level of training, right? And they're not become specialists in spiritual caregiving, but how to screen, how to assess, but how to remain supportive and offer that generous level of support to the patient when there is an identified need, especially within the field of palliative care, where this is a major domain of how we assess and respond. It has a lot of implication with our training as palliative care practitioners, right? So it involves a lot of more training, probably that we have not received in medical school or social work or any other discipline, right? So that's to begin the conversation. I'd love to hear what others think about this as well.
Yeah, we have a few things in the chat here. Brent Peary from Memorial Hermann has put something in the chat. Brent, do you want to come off mute and tell us what you were sharing?
Yeah, it's just an old article that illustrates in a small study that nurses asking whether or not someone wants to see a chaplain is not all that effective in terms of getting a chaplain in the right room. That people, it's dependent upon the knowledge of the nurse about the training and interventions of chaplains, which varies greatly. And so this one article discourages the practice of nurses asking whether or not someone wants to see a chaplain.
Yeah, thanks, Brent. Hopefully, actually, what Brent just said is actually not news to people. That we have, over the last 10 years, really tried to discourage kind of a straight up asking, would you like to see a chaplain? There's a lot of reasons for that. One is that people actually often don't understand who chaplains are and what they do, and they kind of have some really unhelpful stereotypes about that. So it's more helpful actually if you have some kind of screening protocol, or if you more informally as a clinician you sense a patient's distressed, if you actually just recommend the chaplain on the team or the chaplain on the unit visit the patient or family and introduce themselves and offer their services. Often when somebody is as charming as Edward or Brent comes into the room and says, I'm the chaplain on the unit, and I just wanted to kind of check in and see how things were going. And, I've heard maybe that you've had a difficult week. Often that actually makes a very big difference about how people receive and accept the chaplains. So again, to kind of undergird what Brent said, we generally don't think that it's helpful to ask patients if they want to see a chaplain, in part because they don't understand who chaplains are, what they do, in part because you could get in that situation where exactly the patients who have the most intense religious and spiritual struggles say no, and then your hands get tied and it's not easy to follow up on that. Let me just say that when we developed the RUSH protocol, we actually trialed it in the medical rehab unit at Johnson R. Bowman, and the psychologists were doing the screening for us. And our recommendation was if somebody screened positive, the psychologist didn't ask the patient whether or not they wanted to see a chaplain. They just, took that as an indication, as they would other clinical indications, that a chaplain referral was called for. The psychologists were uncomfortable with that. They said, if the patient screens positive and I'm going to refer the chaplain, I want to tell the patient that I'm going to do that. So that then brought up the whole question about, well, what, you say to the patient, look, I've asked you a bunch of questions to get acquainted with you. And some of the things you've said to me today make me think that having a chaplain from our team stop by and visit will be helpful for you. And the patient says, oh, God, no, I don't want to see that chaplain. Right? And so then you're stuck. Right. And, as we brainstormed with the psychologists, one of the options we considered was for the psychologist to say, we're certainly going to respect your wishes here, that if you don't want to see the chaplain on our team, you don't have to. But I want to tell you that I've been here, for a number of years, and Edward and I have been working together for a number of years. And he's really a very sensitive and thoughtful person, and the patients really enjoy talking with him. So I really like to kind of ask you to kind of think this over for a minute, because I think you'll enjoy talking with Edward. And I really, if you don't, after you meet him, if you don't want to talk to him anymore, that's fine. So that kind of engagement may also be one way to work with a patient who kind of, has some negative reaction to the notion that the chaplain on your team is coming in.
George, if I may, what I
Please.
really appreciate you highlighting also is the connection of one, identifying their values and their needs and aligning it with what you are recommending it, and that it makes sense to not just ourselves as a clinical team, but it makes sense to the person, right? And I say that because I've encountered this even when palliative care is recommended, right? Like, should we call palliative care, right? Or any other clinical team, right? That it has to make sense to them of why something is being recommended, right? And aligned and presented in such ways, right?
Thanks. Yeah.
Anyone else?
Laura has a comment in the chat. Laura, do you want to come off mute and tell us what you've written here?
Sure. I'm in the Transforming Chaplaincy Mighty Network, and Paul Galchett is regularly posting really great research articles in there for us to read. And he posted a brand new one written by some hospice nurses about what they saw as the relationship between spiritual pain and physical pain. And in hospice, somebody admits to hospice, the nurse and the social worker are obligated to see them within 2 days. The chaplain is obligated to see them within 5 days for a comprehensive spiritual assessment. And what these nurses were saying is there are some cases in which we need to get the chaplain in there a lot sooner because their spiritual pain is affecting their physical pain. And basically, it's not going to do us any good to just treat their physical pain. We need to get the chaplains in for a spiritual assessment sooner than 5 days. So I thought that was interesting. It speaks to the need for some standardized ways of doing that screening.
Thanks, Laura. And actually, Paul Galchett is on the call. I've just asked Paul if he can throw that reference in the chat for everybody.
Will do, George. Thanks.
Thank you. Anyone else? Something you're noodling on, a question, an insight that you want to share?
Suppose that someone that, again, a clinician is doing the screening in a setting without chaplains, outpatient settings, for example. Who would you recommend referring that person to, or what kind of a link would you suggest?
I'm going to give this one to Edward. You're asking tough questions today, Stan.
Yeah. Stan, I guess I'd be curious about what are the resources available in the outpatient setting, right? So I don't know if there's depending on every spiritual care department is so different and what they are offering in terms of inpatient, but also outpatient. And so yeah, go ahead.
A lot of the agencies I work with are social service, senior care, outpatient mental health, individual private practices. So there isn't someone on staff that has spiritual training.
Yeah, it's tough,
Like,
Stan. And the
yeah.
question is, does the patient themselves, the client, have a religious or spiritual advisor they trust? It may be that if they do, and that person actually understands religious and spiritual struggle and pain as part of a journey of faithfulness, that person's going to be a great support. But it may be that the person might not have an open view about this, and they might see religious or spiritual struggle as a sign of unfaith, and they'll just make it worse. So, and then if people are not connected to local religious leaders, there are pastoral counselors, as you know, or they're actually, right, so we now use the term spiritually integrated psychotherapy. There are psychotherapists who have strong training in religious and spiritual issues. Ken Pargman is working very hard actually to increase the training among psychologists and mental health practitioners to be able to address issues like this. But then, you get into the issue about whether or not somebody can get an appointment and has insurance or something that will cover it. So it's a tough area, actually. We're coming down the home stretch, but Denise has put herself off mute. Denise, are you going to say something?
Oh. I had thought to, yes, thank you. I just wanted to add, I don't want to be overly idealistic, but it may also be kind of a field of dreams sort of thing. Build it and they will come. I'm just thinking about for our institution, a large healthcare system on the West Coast, we need outpatient chaplains, but professional board certified outpatient setting chaplains. And we have to build a case for that. So I would, the need is not being met. It will only get met if the healthcare system sees the value and that it's being asked for. So if those screenings are done, collect that data, partner with your, however close you can get to a professional chaplain in your organizations to try to start making cases for that. It's critical. That's my thought.
Thank you, Denise. It's I want to say that's a great way to end, that there is a lot of work and collaboration to do together, right? And thank you all for joining us for this great presentation, number 2. And the third one will be on Friday, wrapping up our 3-part series, okay? Thank you, everyone.
Good to be with you. Take care, friends. Good to see you.
Thank you.